We are starting the live streaming of this meeting now. Jackie Allen, the new chair of the CHC, and I have agreed how we're going to handle this meeting, which is why I'm starting the meeting, and I will deal with the first few items, then hand over to Jackie. Some words from me by way of introduction. I first of all congratulate Jackie on being reappointed chair of the Community Health Council. Thank you very much, Jackie, for stepping into that role on behalf of our board. And we look forward to working with you and Jeff and your colleagues moving forward. So some other updates from me by way of introduction. So Joe Whitehead, our new Chief Executive, is preparing for arrival, as you might imagine, in January of this year. She's been liaising with myself, Jill, Sue and others in terms of the run-up to her starting. In the meantime, Jill has stepped into the interim Chief Executive role, and Tracer has stepped up behind her as Deputy. And with the support of the team, they're leading the organisation and leading the organisation well, from my perspective. You will appreciate, I'm sure, everyone on this call, this is a really challenging time. Trying to manage the response to the pandemic whilst keeping the services going and working out to restart planned services is complex in each of their own rights, but more complex by having to do all those things and many others together. But there is a lot of work going on around that, and you'll hear more about that during the course of this meeting. I want to express my appreciation for the leadership that's been displayed by the executive team and others in the organisation, and particularly by our frontline staff who I've had the opportunity to meet in locations, for their bravery, for their professionalism, for the commitment and for the flexibility they've shown in supporting the frontline workforce from different areas of our organisation. There are, notwithstanding the challenges, some real reasons to feel optimistic about the way forward, and notwithstanding the pandemic, as you know, is well and truly still with us. The first is that we are due to discuss as a board and agree, one would hope, for submission to Welsh Government this afternoon, the plan for the next quarter, which is derived from a lot of work by the organisation to get it into a fit place and to clearly describe what we will focus on for the next few months and beyond. We're also due to discuss and approve this afternoon a winter resilience plan, and you'll realise the challenges that we face around responding to the pandemic, doing all those other things I've referred to, and dealing with normal winter pressures too. And also there are a number of things alongside that are taking place. So you will have seen the announcement of a task force to be established to examine the business case for a medical and health sciences school in North Wales. I think that is a really important development, and we are in discussion with Welsh Government about how we bring that group together with appropriate terms of reference to move that piece of work forward. The second that the dialogue continues with Welsh Government around support that they might provide to us over the coming few months to support the search for further transformation and improvement in a number of our key services, and particularly around planned care. And in that regard, some of the conversations that were once taking place in the organisation are taking place in a different sense as a result partly of COVID. So there are certainly different conversations taking place amongst our consultant and clinical workforce around the notion of doing things once for North Wales, around how we might reconfigure some of our planned services across the region to help pick them up and improve the amount of services being delivered during this challenging time. And you'll hear later references in that regard to the orthopaedics business case being revisited, no doubt to the considerations that we're giving to diagnostic and treatment centres being established in North Wales, and also some particular work around other specialist areas of planned care. All of this is importantly being informed by, in my view, a better understanding of the demands being placed on the organisation and the capacity that we have to bring to bear to deal with those demands. And in that regard, the loss of capacity that we've witnessed in terms of our English providers in recent months. So I think the work that's now going on is better informed by the evidence and by information that we had for a while but have not used appropriately. And that should give us some confidence in terms of the dialogue that we have with Welsh Government moving forward, the support that we might be able to secure for what we want to do. So without further ado, I'll stop there by way of introduction. Just to let you know, Emma Scott has asked to observe the meeting. Emma is with Health Inspectorate Wales and no doubt she's on the meeting, so she's viewing the meeting in her own right. So, apologies for absence. I have received apologies from Morwenna Edwards, from Andy Roach, and from Helen Wilkinson, and also from Linda Harper and Gordon Hughes. Does anybody know of any other apologies that I should be recording? No? Okay.
Mark, Chair, if you'll excuse me, just to alert that we have the SCG going on at the same time as this meeting. So consequently, Teresa and or Chris will dip in and out because we need to support that meeting from a health board perspective as well. Just wanted you to be alerted.
Okay. I was going to come on to ProScale, but someone has got their mic on, it would appear, because I can keep hearing typing. So can we just mute the mics? So that's apologies for absence. Any declarations of interest from colleagues for any items on the agenda? No? Okay. The draft minutes have been circulated from the meeting of the 10th of October 2019. Are colleagues happy with the accuracy of the minutes? In the absence of comment, I assume that's the case. Yeah, okay, thank you. The actions from that meeting are listed. Chris and Sean, there was one action for your good sales around meeting. Has that meeting taken place? I think it was due on the 12th. Chris, Sean, have you met?
Sorry, yes, we have met. We met a couple of days ago, had a really good discussion with Jeff and Carol in regards to 4 points really, but we've looked at those and we've passed on our concerns, which Chris to some of them agreed, and it's on their agenda. I think that would be about right, wouldn't it, Jeff?
Yes, that's correct. Very satisfied with the answers we had from Chris. As the chairman has said, much more is being learned as we go into this pandemic.
Thanks both. Okay, so before I hand over to Jackie for the first substantive item, just in terms of protocol then, we believe you can put your hands up if you wish to answer questions by hovering over your name on the screen. If that doesn't work, by all means, turn your video camera on and Jackie or I will come to you when we see you come on by way of video. And alternatively, if neither of those two things work, but you've got audio, if you indicate by audio you want to come in, then we'll facilitate that too. So hopefully by one of those routes, you will be able to indicate, including Jackie and I, whether we want to ask a question, and then Jackie and I will bring you in. Okay, so without further ado, I'm going to hand over to Jackie. Thank you.
Thank you very much, Mark. And thank you for those kind words. It is appreciated. And we do appreciate taking the time today to actually come and sit around the table with us. We know the difficult times for you and your board, and it is appreciated that you've managed to take the time out to do this. We'll go to the first agenda item, which is agenda item 5.1, which is a COVID-19 update from Dr. Chris Stockport. Is Dr. Chris Stockport with us?
It's Teresa here. Chris has gone on to SCG because we're both doing a balancing act between meetings today, Jackie and Chairman. So I don't think he's with us just at the moment because he's also kicking off SCG, but he should be with us later when I'll dip onto SCG instead.
Thank you, Teresa. In that case, perhaps it might be as well to go on to your agenda items, Teresa, if that's all right with Gavin MacDonald.
I'm content if Gavin is, and if you're willing, Jackie and CHC colleagues.
We're happy to move the agenda about to accommodate you. So I'll hand, if Gavin is willing to drop down the agenda and there's no time constraints.
That's absolutely fine with me. That's fine with me. Thank you.
Thank you. So I'll hand over back to Mark to take Teresa's items. Thank you.
I think you're on mute, Mark.
You're on mute, Mark.
Sorry, apologies. That's the first time that's happened, I think. So, Teresa, feel free to speak in Cymraeg, but translate for us, please, if you wish. So the first item is immunisation.
Teresa, you're on mute now.
Is that better?
Yes.
Can you hear me now? Yep, thank you. So I can talk about flu and COVID vaccination, but I was aiming to update you in the main around our preparatory work for COVID vaccination should a vaccine become fully available for us to use. But as CHC colleagues, I hope you'll appreciate we have plans for mass vaccination anyway, given occasionally we have to do additional vaccination around things like measles, etc., when we have outbreaks. So we have fairly decent and well-rehearsed mass vaccination plans for North Wales. But of course, we are now planning for something which I would say is on a much bigger scale, which is the potential for a COVID vaccination. And I am saying that because at the moment we're still waiting on formal information on if a vaccine will become available. You'll have read in the press about the Oxford vaccine, I'm sure. Also working through issues such as, well, how many doses of the vaccine might we receive? And also in terms of who would be the priority groups for the vaccine. So just to give you an overview, we have a North Wales group on immunisation. So that's our SEG, a strategic immunisation group. That's what sits within the Health Board. They lead for us on flu vaccination and any other vaccination programmes. So as part of that group, we've now set up a tactical group across North Wales. And in that meeting, we've brought in colleagues from not only the Health Board, from the partnership arena as well. So we have colleagues from the local authorities, but also we're linked in through the LRF, so we've got all those other support mechanisms. And I think a key meeting for me to mention is there is a weekly meeting at Welsh Government level to give us updates on where the planning assumptions are. So our key work at the moment are around a number of subgroups which are liaising on logistics. So whether that's to do with how we will keep the vaccine once we know what type of vaccine it is, lots of caveats in this, where we will store the vaccine. There's some of the easier things, but then also thinking through now currently, where might we hold those vaccination sessions? Because of social distancing, it's not your usual social event that sometimes mass vaccinations are. And many of you will be aware of that through the flu vaccination programmes. One of the biggest challenges for us, of course, is on the workforce elements. So with everyone so busy at the moment on just general work, trying to keep some business as usual going, because COVID activity increasing, as we know, across the region just now, it is a challenge to consider the workforce. Our workforce are currently in primary care working very hard on flu vaccination, and we are encouraging everyone to go for flu vaccination early, because some of the working assumptions that we have is the gap between a flu vaccination and a COVID vaccination. And so thanks to Sue and her team, but also to other workforce colleagues across the region, we are trying to work through what are our options, the training, and there are discussions underway nationally about maybe allowing groups who don't normally vaccinate to support us in our endeavour this year. And I think that that would be a very sensible way forward. At this moment in time, I'm not thinking that the vaccine will arrive very quick, but I am certain that when it does arrive, it will probably come in small amounts and grow. That's normal for all vaccination programmes. So I normally start flu with a few doses and then I get the more substantial amounts in a few weeks after that. And my working assumption, but maybe it is just that, is it'll be the same for COVID vaccination. Anyway, you have just limited information for you on the slide there. The flu vaccination programme is going well. I'd like to say that, and my thanks to the population of North Wales for supporting us, for our staff here in the Health Board, but also for everyone who's involved in the programme who've worked at pace to get our rates up high. And I'm looking forward to seeing more statistics on both the community uptake, because we do need a high and good flu uptake this year. I think that will be helpful with all the respiratory conditions, but also we're trying to get as much of the flu work through quickly in case there's any change in the COVID vaccination and in case that comes quicker than we are currently planning. But plans are underway. I'll stop there, Chairman, and take questions if that would help.
Thanks, Fraser. The presentation wasn't displayed, but it has been circulated. So people have got access to it. When we come on to your next item, we'll make sure that John loads the presentation before we start. That was my fault. But so any questions from colleagues? No? Okay. So we'll go on to testing. John, can you load the presentation for Fraser, please?
So if I just talk a little then, so we're on test, trace and protect, and maybe on this one I should do this one in Welsh, Mark, just if we have translation facilities available. Okay. Na I siarad yn Gymraeg. Wedyn, da ni wrthi ar hyn o bryd ar yr cynllun.
Sorry, we don't have translation facilities available. So, but by all means, can you translate what you say in Welsh? And I know it will take longer, but that would be helpful, I think.
Okay, then apologies, everyone. So I'll try and do it bilingual. The slides are bilingual for everyone, and I'm happy to take questions in English or Welsh, of course. So if I start with test, trace and protect, 3 elements, test, trace and protect, and I'll just take each one, give you a brief update on where we are. And I have to say the fantastic work underway across the partnership. This is a partnership activity right across North Wales, and I'd want to say that loud and clear at the beginning. Felly, ddechrau ar y gwaith profi, da ni wrthi'n profi pobl sydd ar gymuned hefo symptoma. Da ni ddim yn profi yn asymptomatic ar hyn o bryd. Dydy hynny ddim yn addas, oni bai bod yna rhesymeg gwyddonol. Wedyn, da ni yn pwysleisio'r gwaith profi yn gyffredinol. So the testing is the key part of the programme and starts the process off. We are testing at the moment in terms of symptomatic individuals, not asymptomatic unless there's scientific reasoning for that. So many of you will know we are testing in care home staff, and that's a specific ask from Welsh Government. We are following the Welsh Government arrangements on testing, and things are changing. There are new discussions underway. And perhaps on testing, I should say that we start with sampling, and that's where the Health Board really gets underway, is on the sampling. And then much of the testing, of course, is undertaken in the laboratories, and I'll come back to that. Ar yr ail rhan, mae gynnon ni'r gwaith orhain, a hynny ydy, da ni'n cysylltu efo pobl sydd wedi derbyn prawf positif a wedi cael y gwybodaeth yna I fod. Da ni wedyn yn dilyn I fyny hefo galwad ffôn I rhoi cyngor iddyn nhw, ond hefyd wedyn I cadarnhau pwys maen nhw wedi bod mewn cysylltiad hefo nhw, fel bod ni'n gallu rhoi'r gwybodaeth addas a'r canllawiau iddyn nhw ar beth I wneud. So the second part of our programme is tracing, and actually, so we give information to the index case, the person who's been found to be positive. That's kind of a key stage in the programme. But we have a team of people who are supporting them to identify contacts so that we can alert them so that they can self-isolate as positive, as appropriate. And that's very important for that group of people, of course. And that for us is a way of helping to break the cycle. And never has that been more important than as I speak here today. And then thirdly, yn drydydd rhan ydy'r amddiffyn y protect. A mae yna ddiffiniad arbennig I hwn o ran y canllawia TTP. Hynny yw i'r pobl heina sydd yn perthyn i'r grwpiau bregus, bod ni'n rhoi'r cyngor a'r gwybodaeth iddyn nhw, fel bod ni'n galluogi nhw I fyw yn saff ac yn ddiogel yn eu cartrefi hunain a rhoi'r cymorth da ni angen iddyn nhw. And so through Protect, we're trying to support those vulnerable individuals. Some little bit more detail on the different elements. So if I start with testing, antigen testing is what we're mainly undertaking in North Wales. As I say, that's for those who are displaying symptoms. We have our own community testing centres in Wrexham. We also have them in Bangor. We also have a team at Glenclwyd and we have a team at Allwen, and that's an important team to serve the Meirionydd area for us. But we also have the mass testing units, which are in Llandudno and Deeside, And of course, people can also access home testing kits. Some of you will have seen the press today. We've opened up a mass testing unit in Wrexham, which is a small mobile version, and potentially that will move in the future, but for now we've placed it there, and thanks to colleagues in the council. And we're also developing local testing units, so the menu of testing option increases. For antibody testing, we've been undertaking antibody testing for specific groups as per guidance, and thanks to Adrian Thomas, who's been leading this work, we've already undertaken over 14,000 tests. We're now pausing some of that programme so that we can actually concentrate on the antigen work, but happy to take questions on that. Ar y gwaith o'r-rhain, da ni wrthi hefo system sydd ar draws y cynghorau sir a ni fel bwrdd iechyd i wneud yn siŵr fod pawb yn cael cysylltiad o fewn 4 awr ar hugain neu cyn gynted as impossible. So we have a team across North Wales. In the Health Board, we host the regional hub, and the 6 local authorities all have local teams of contact tracers and advisors, and they are working every day to try and contact those contacts that we find through the testing, and then to contact all their contacts as appropriate. It's quite an industry, I may say, but my sincere thanks to partners. You'll see the big numbers at the bottom of the slide, but everything we are doing is trying to reduce the spread of the virus. And I'm happy to take questions on what is a significant piece of work with partnerships. In terms of assurances, I report formally through the board here, through the SPPH committee, and then I also provide updates to the regional coordination group and currently the strategic coordination group. And I gymryd cwestiynau. I'll take questions, Chair.
Okay, before I open it up, can I just commend you for the leadership you've displayed in this area, Teresa? As you know, and some colleagues know, I have regular calls with the leaders of 6 local authorities, and the leadership in that regard is evident because they recognise it too. So on behalf of the board and the communities of North Wales, thank you. Diolch yn fawr. Okay, any questions? I can't see any hands. Anybody want to pose a question? I can't see any videos coming on either. But I'll pause in case someone wants to come in. No? Okay, all right. So, Trace, I suggest we stick with you then. You're on a bit of a roll. So should we leap to mental health at item 6? And John, can you load the presentation, please?
Thank you, Chairman. I've recently taken over the executive leadership of mental health, and I'd have to say I've had a fantastic welcome from all the team on mental health and learning disabilities. I only have a few slides. I'll go through them in English just for expedite time for everyone today. I'll start with the first one, if I may, John. Thank you. So just to give you an update on where we are on some of our key work. So some excellent work now going on with primary care, and I know we've had issues in phase 1 in terms of some of that discharge piece of work, but we are regrouping, and the team have really taken on board the need for us to work with our primary care mental health teams. Such good work happening at the moment in terms of face-to-face and virtual, and we're using very much the transformation monies will support us to take that work forward. For me, that is key, and the division are clear it is key, as we are aware of the significant numbers of getting more anxious people in the community. It's a very low level, but for those with mental health issues currently, what COVID might be making an even worse situation for them. So that work at the lowest level with primary care is key, and that's where we're putting a lot of energy for the future too. I'd like to mention Consultants Connect, which is an opportunity for our GPs who have any specific questions to connect with the consultants. And people tend to think we're only doing this on physical health, but the arrangement is also in place for mental health. And I'm getting good feedback from both sides that it's making a difference, and certainly for the division, that's key. The Silver Cloud got lots of mention last week in the press, and that's really groundbreaking territory for us. But it's some online courses to support people with mental health issues, and something we'd like to grow and develop, but happy to share more information on that with any individual, and even just to spread the word. We certainly tried to get some publicity out last week. In terms of the community mental health teams, they're all up and running. Appreciate some more staggered than others. That's mainly to do with social distancing. And of course, we have some backlogs, but we're working through those. And I've just been given the numbers, so I'm clear on the work that we need to do there. But just to let you know, they are open. There are no issues there. We are moving forward with that. In terms of our older people and mental health work, our memory clinics have reopened. I know we paused. But as a key service for us, they again have reopened, and those community services that we have are fully functioning. Would you mind just changing the slide, John? Thank you. In terms of inpatient care, we are continuing to cohort, and we're reviewing all our plans now as looking to the winter, as all my colleagues and Gavin is with the secondary care. We're doing the same in terms of our inpatient care arrangements. And with Mike and Ian at the helm, and they've really been out and about in our wards and areas at the moment, certainly making sure that they are robust going forward. No issues with substance misuse services at the moment, and actually some of those work that we do in partnership haven't really stopped throughout phase 1, and I think that shows the dedication to the service across the partnership in North Wales. The forensic work is great moving forward, and Tir Llywelyn, I know Ian visited the other day. In terms of learning disabilities, again, under Will's support, moving that forward as well, just putting those plans on paper, firming them up so that we can share the relevant updates. We're waiting for Welsh Government monitoring approaches as well in terms of all our services, not just learning disabilities. We have reintroduced the experience group, the patients and care meeting. Mike kindly chaired the first meeting, and we do our second one soon. I think that's a real important piece for us going forward, and that's acknowledged within the division. And finally, the stabilising senior leadership. We do now have Alberto, Medical Director, Mike, Nurse Director, Ian as Overall Director, and myself in place. We've been making safe and making sure all the connections in place are there for reporting. And now we're working through some of the perhaps more granular detail, but going forward, also thinking about what structure will work best for us, and we'll be working with our partners on that. And finally, a slide just in terms of trying to simplify things. You'll all be aware that we paused the phase 2 plan. Jill, Lucy, and certainly when we were at the Together for Mental Health Board meeting recently, some of the humbling things we heard there, we have paused phase 2. And one of the intentions in the division as we stabilise and regroup is to simplify things. And my thanks to colleagues as we've agreed 4 priorities to focus on for now for Q3 and 4 over the winter. And that is that we will have that stronger divisional management. I call it getting back to basics to some extent, so that we've got good foundations to build on. We really do want to engage better, and that's engaging within the division, but also with partners, and that includes, of course, yourselves, the CHC, and we're looking forward to that meeting on November the 5th as well around the Hascas and Ockenden. So really regrouping on that and putting energy into that element. We're going to establish the review of capacity and capabilities. Much of that has been done in terms of our winter planning, but there is an ongoing piece of work for us there. I have to say there was a clinical meeting, the clinical advisory group met this week, and that was I've had feedback from it from a number of clinicians, and they felt it was a very rigorous, transparent meeting, and I think that holds us in good stead for the months ahead, but also longer term. My mind is not just on short term, it is on that medium to long piece. We must have strong mental health and learning disability services. And then finally, in tandem with that, it is that clinically led, safe and effective services. So, you know, we want to hear the voice of the patient, the carers, the families, but we also need that clinical leadership within it. And I feel that everyone really wants to move in that direction. And as we put our future plans together and think through all the committees that we report through, that's key. And actually that links nicely with the transformation monies, which of course we are still working aligned with the RPB. And as you can see, the patient experience group, that's already up and running. I leave it there if I may, Chairman. Diolch yn fawr iawn. And take questions, of course.
So
hopefully colleagues on the CHC will get a sense of the fact that we hold some concerns around mental health, which we've been seeking to respond to on a number of fronts. I know there was a meeting held quite recently between some of the executive team, Jeff, Andy and others. So Jeff or Jackie, I don't know whether you wanted to give your view on that meeting or what Teresa's just said.
I wasn't at the meeting, Mark, but I would like to make a couple of points. 2 months ago, the CHC were encouraged and welcomed a report that went to the Quality, Safety and Experience Committee. This report was written by Mike Smith, the Interim Director of Nursing, and it highlighted key issues of significance that he'd found after only being in post for a few days. Its comments backed up and supported some of the issues that we'd found. And we've been concerned about these issues over a long period of time, such as lack of stability, as you've mentioned, consultation with partners and staffing issues. Part of his paper listed some key priorities and activities to remedy and mitigate the key issues. And I'm pleased to see in your presentation today, Teresa, that you have mentioned quite a lot of these issues and some of the issues that you're putting in place to rectify these. We know it's not a quick fix, and we would welcome the Health Board to continue to keep us in the loop as one of your partners. You mentioned in your presentation other partners, but we would strongly like to continue as part of your partnership working and become totally engaged fully in the future. We'd also like to see an update version of the report written again by Mike Smith, say when he's been in post another couple of months, to evaluate any changes made from his point of view. So that's all I'd like to say of things that have happened since I've taken over the chair and that I found out about. So I'll pass to Jeff. Do you want to come in?
Jeff, do you want to go next? Then I've got Sean and Teresa and I will respond to all the observations in one go, I think. Jeff? Yeah. You able to get in, Jeff? We can't hear you.
I am unmuted.
Okay, all right, can hear you now.
Yeah. We had a meeting with Teresa, with Jill, with Ian, and we talked about ways of engaging with the public in the preparation of a refocused phase 2 document. It's good to see in the presentation that these issues are being picked up. We've been able to have frank conversations with Mike Smith and with Ian, with everyone really, we see it as a real sea change in how mental health is being looked at. And I think if we add into that the fact that there's now a Minister for Mental Health whose sole responsibility is mental health, I think we're starting to be in a good place. Thank you. I'll mute myself now.
Thanks, Jeff. Sean, did you want to say something?
Yes, please. I just wanted to know, really, is CAMS covered by yourself, Teresa?
Thank you. If I answer that one first, then no, that's a very easy answer for me. No, that's with Dr. Chris Stockport. But of course, given children grow up and become adults, that transition piece for me is ever so important, because I know from working with children's in the past and working with Chris that we need to get things correct. So at this moment in time, CAM sits with children, but certainly Chris and I are linking in closely given that transition piece. And that's so important for us, especially during COVID. I know that that's always a vulnerable time and lots going on in people's lives. We need to get that right. So that one's the answer to that one. But if I may come back on the others as well, Mark, or shall I take more questions?
Before you do, hold on. So Jeff, I think you wanted to come back in.
Yeah, just to say that in the engagement work that we've agreed we'll do jointly, we have agreed that we will include CAMS as if it were within the directorate because of the very important transition. So I'm really pleased by that. I think that's excellent. Thank you.
Sorry, can I just come back in?
You can, of course you can, yes.
Thank you. Can I just make a declaration of interest before I ask the next question? I have a grandchild that's in the CAMS service, but the question I wanted to ask, which I asked about 18 months ago, is do we have any statistics to show how many children actually go into the mental health team, the adult mental health team? My reason for answering that is then it gives somebody some idea of what prevention measures they have to take with CAMS and how much more effort they have to put in it, and also that these children are suffering with COVID as well. Thank you.
You're on mute, Chairman.
Sorry. Lucy, did you want to comment before I bring Teresa back in?
Thanks, Chair. Yes, I just wanted to, I can't answer Sean's question, I'm afraid, but I just wanted to add that to echo the comments that have already been made in relation to the challenges that we're dealing with in mental health, but also it's really good to hear from CHC colleagues that they can see the direction of change in relation to mental health. We are absolutely committed to trying to sort this out. We need to be open and transparent about it, about the challenges that we've faced. And I'd like to thank Teresa for the amount of effort that she's put in to, and Mike and Ian as well, to actually trying to unpick some of these challenges and her commitment to moving those forwards. Speaking to colleagues already across the division, you know, I can see a change as well, and we're trying to get the priorities right. We're also committed as well to the Together for Mental Health Partnership Board. We're going to be reviewing the function of that partnership board and the membership as well to make it a lot more dynamic. And I'd certainly welcome conversations with CHC colleagues on how they may be able to support us in that direction as well. Thank you.
Thanks, Lucy. Cheryl?
Thank you very much, Chair. I'd just like to really echo some of the words from Lucy, and also to say how much renewed focus Teresa that myself, Lucy, very early now with Teresa and Children's Services covering the whole of North Wales, and we are pushing as hard as we can on children's mental health. Very, very important, but the focus is there now and the drive, and I'm extremely pleased to see this. Thank you.
Okay, Tracy, I think it'd be helpful to receive comment from you on some of the observations made. So Jackie and Mike bringing another report back to QSC and engaging the CHA in that regard. How are we going to move forward with the engagement that Jeff has referred to in terms of involving our CHC colleagues in that work? And finally from Sean then, the link into CAMS and how we're going to pick that up. I hear you say that there's dialogue going on with Chris, but it'll be helpful to get a sense of that moving forward and also have some sort of report back on that too.
Thank you, Chairman. Diolch yn iawn. Gosh, where to start? And thank you for your kind words. Everyone is doing their best, I have to say, feeling a new energy, and we are going to build on the assets and strengths that we have. And I look forward to working with you all in CHE. It does feel this is partnership space, if ever there was, and we need to get it right. So taking them one by one, and I wanted to mention, I think the Minister for Mental Health, I'm sure, will make a difference in the background for us all. Without mental health, there is no health. We all know that. So I do feel that will be support for us. In terms of some of the issues then, yes, on the paper to QSE, the division are planning a paper to board. Jill has requested an update to board in terms of where we're going, where we're at. And so that's on the cards and the team are planning, and we can work on the QSE paper as well. So thank you for that suggestion. In terms of that work with the CHC, Lucy, you've already said it, we're regrouping on the Together for Mental Health Partnership Board, but there are also other opportunities, and so Amanda Lonsdale is currently with us, and we'll work through some of those and look forward to those ongoing discussions. We do need your support and lens, and your visits in the past, I know, have always been significant moments in terms of looking at the services and giving us that fresh pair of eyes in terms of the work. In terms of CAMS, I'll take that one away and pick up with Chris and probably bring that back to board and add that in the QSC. And of course, I will keep CHC updated as appropriate. So we'll work on that one. And then for Sian, I'm sorry, I don't have that statistic at hand. Apologies, Sian, but I can work on that one for you and get back to you via Jeff, I'm sure, Sian. So let me work through that one and get back to you on that specific ask. But overall, I'd just like to say, if I may, we will try and work better with you as a CHC and with our partners in general, especially through the winter, which I think is going to be hard going. But I know Chris will give you an update on COVID later.
Yeah, Tracer. So that's all the items or questions I've got flagged to me. Those who put their hands up already, can I ask that you put them down if you finish, so I can, we're putting on to work out who still wants to come in. But at this point, I don't think there's anybody else. Tracer, can I ask, now that you've dealt with your items, that you substitute Chris at the Strategic Coordination Group meeting?
Of course, thank you. Thank you.
Thank you. So we'll stop that there. Jackie, I wonder whether we ought to return back up the agenda to the safe return to services with Gavin.
Yes, I think that might be a good idea.
Okay, can I hand to you then?
Yes, thank you, Mark.
Mark, can I just interject, Teresa? There is no need to now because we've just finished SCG.
Lovely, thank you for that information. We'll give Chris a minute and we'll go to your presentation, Gavin, if that's all right with you, which is on safe return to services.
Yes, good morning, everybody. For those I haven't met, my name's Gavin McDonald. I'm the Interim Chief Operating Officer for Secondary Care. I've been in the organisation 3 months. Just wanted today to give you an overview of where we are with the safe restart of planned care. And probably really important to start off with the context of this first, context of what we're working in first. So if we just go to that first slide, please. It's fair to say planned care has been significantly compromised because of the first wave of the COVID pandemic. And that's for various reasons. Some of that's around the patients not choosing not to come in for their operations into a COVID hospital. Some of that's around the fact that the hospital's had to reroute some of its resources from planned care over to emergency care. But the kind of net result in that is across the country, so this is a national picture, patients are waiting longer for their planned care operations. And within the health board here in North Wales, we've got over 40,000 patients waiting over 36 weeks. And over half of them are waiting over a year, which is a really concerning to have, but does map across in terms of what the rest of the country is looking like. So over the past few months, we've been restarting planned care when it's been safe to do so. We're back up to, so we look at our theatre activity, so the number of cases we've been doing through our operating theatres, we're probably back up to around 60% of what we were doing before the pandemic started. And the reason for that is because it's just more challenging in terms of the turnaround time for each patient having their operation. So, for example, the whole decontamination after an operation or after an outpatient appointment. In outpatient, some of the rooms have to stay empty for an hour before they could be cleaned. staff have to put on gowns, so the putting on and the taking off of gowns takes time. So the whole process of seeing care does take longer. The good news is all our really critical, essential services are currently maintained. What we've done in terms of all the patients that are awaiting procedures is we've done what we call risk stratification. So some of those patients on our waiting lists will be more urgent than others. So what we've done with the clinicians have prioritised patients in terms of those that will be most urgent and those that are perhaps more routine, that could wait a bit longer. So we've got a really good understanding on our waiting list now in terms of who's the most urgent patients that have to have their operations. In terms of going forward for the next 6 months, obviously it's having this discussion when we're in a second wave. There's a degree of unknown as to what's going to happen. We have done some modelling in terms of what COVID might do in North Wales in terms of impact on each of the 3 areas. And we know we're working on the assumption that we're going to peak over sort of December, January, in terms of that's when we're going to have the biggest impacts on our sort of bedded capacity. So the context of that's really important. But what we're currently doing in terms of, there's 4 key specialties there. So you'll see on the next slide, lower GI, endoscopy, cataracts, and urology. We're using something called a once for Wales approach. So in terms of that risk stratification, we're looking at our capacity as a whole as a health board. So the patient with the highest need gets the first available slot in terms of theatres or bedded capacity, and that allows us to have a more equitable approach across the health board, so that it's not it doesn't depend on where you live in North Wales. It's on clinical needs, so patients are offered a choice in terms of maybe a West patient going to the centre for the procedure because there happens to be capacity there. But the important thing is patients are offered a choice on that. We've done a fair amount on virtual outpatient appointments. So a lot of our follow-up appointments now are done through either telephone or through a video link, something we call Attend Anywhere, which is a national programme where patients can dial in and have their consultation remotely. And there's a number of things we're doing in terms of trying to help productivity. So I talked about the decontamination issue, particularly in outpatients and theatres, and we're exploring whether or not we could bring in some cleaning teams to sort of focus on turning around spaces quicker. So we're just working out that option currently. I think it's probably a real goer for outpatients, probably less so in theatres. Pleased to say that all our national screening programmes have recommenced, which is really positive. And just cataracts, because I know previously CHC had asked a specific question around cataracts. So I'm pleased to say cataract operations recommenced on the 10th of August across the health board. Since then, up until the end of last week, we've done 222 cataract operations across there. So lots going on around planned care, and as the chair talked about in his introductions, we're obviously looking about what we might be able to do in terms of a longer-term strategy around planned care and how we're going to deliver it potentially differently. But it's a really key priority for the health board, and we have a weekly access meeting where we review how long patients are waiting and what capacity we have, and making sure that patients are being placed on clinical need. And then we have a weekly planned care group as well, and the access meeting reports into the finance performance committee from a governance point of view. So lots going on there. So good news is essential services are being maintained. It's a bit of an unknown with the whole COVID pandemic second wave and where we're going to get to, but certainly our planning for winter has been around maintaining those essential services, keeping those going, and doing a higher proportion of elective surgery than we would have done in the first wave of the pandemic. And as part of our winter planning, we're looking at other options to be able to bring some capacity back online. So I can close there. I'm happy to take any questions.
Thank you very much, Gavin. I've got one question, but I'll leave that till the end. Has anybody got some questions for Gavin? I can't see any hands raised on my screen.
Chair, if I may.
Yes.
It's Jill Harris. It's just to add to Gavin's presentation, really. One of the opportunities we're exploring to bring the planned care back online is the diagnostic treatment centres, as Matt mentioned. But essentially, the plans that we're pulling together and in conversation with Welsh Government are to allow us to put in 2 facilities to start to clear the backlog that we've seen grow, but equally to get us into balance moving forward as part of our strategy on planned care. And I think it's really important to know that's not just about surgery. It will be about day surgery, but it will also be about diagnostics. And the second point, I think the chairman alluded to it in his opening remarks, is the learning from COVID is actually now we are seeing our clinicians think very differently, particularly in the way they want to deliver care safely. And that is certainly altering the conversations we're having around orthopaedic surgery, where they are moving towards supporting what they would call a cold elective site. So where there is no risk of infection from patients coming in via an ED department. And clearly, given we're not yet, well, we're far from out of the woods with COVID, so we don't know when we're going to see normal surgery, normal business completely put back in place. It is looking to see how we can mitigate that in the medium to long term. So those conversations are taking place. It would mean a big investment. Our clinicians are very firmly behind that because we're really, really conscious that the delays, even though we're clinically prioritising our patients, are clearly causing harm and distress to patients who are waiting on our waiting list, which were already too long before this commenced. So I just wanted to add that, and forgive me, Chair, for taking up more time.
Thank you, Jill. Have we any questions for Gavin? Gavin,
sorry, Jackie, I did put my hand up. I'm sorry.
I said I couldn't see.
Sorry. It's not a question really. It's just a comment. I'm speaking to a lady who had a swallowing assessment done by phone. And I've got grave concerns that anybody can do assessments such as that by phone. And the other thing I worry about with the phone consultations is that we're de-skilling some practitioners as well. It was just a comment and a concern that I have, that people are being assessed when really they need to be seen for a swallowing assessment, etc. Thank you.
Chairman?
Yes, Chair.
Yeah, I think the numbers are very worrying. At 40,000, 36 weeks plus waiting, we're about 10 times where we would normally be at this point in the year. And the 4,000 was too much, really. And that has risen by about a quarter. It was, last time we had the figures, it was about 31,000. And it's obviously increasing all the time. I totally agree with Jill that it needs to be moving forward and somehow slowing that inexorable rise of 36-week plus waiters. I know this is very difficult, and that the normal solutions that you would have, such as seeking spare capacity from providers in the northwest of England, is not available. But I would very, very much hope that Welsh Government is sympathetic to this, and that we don't have punitive measures for being over referral to treatment times. I really hope that does not happen. Thank you.
Thank you, Jeff.
Jackie, can I comment, please?
You can, Mark.
I think Adrian wants to come in too. I can see the hands by Klinos here. I'll let you know if I see any go up, but I think Adrian wants to come in a moment. Can I just say in response to Jeff's observation that Jill and I and the Pen-y-Cae team had a meeting the other Friday with Andrew Sallows from the Welsh Government Delivery Unit, and we expressed upon him a wish to move forward with the work around the diagnostic and treatment centres, because I do think that is a fundamental part of the solution moving forward to cope with COVID, but also more generally in terms of blanket. I have to say, I thought the meeting was really positive. I think Jill's nodding, so I think Jill found the same. Andrew has been invited to our Finance Performance Committee on the 29th of October, which I chair, because that's when we will expect the next stage of the proposal to be presented. So we're drawing Welsh Government in, Jeff, to seek to move the conversation forward as quickly as we can, because we did start off with the longest waiting list. We have uniquely lost the English capacity we can normally rely on, so we are substantially exposed, and we need Welsh Government support to come up with something pretty radical to respond to that exposure. So I'm more than happy, Jackie, to keep you, Jeff, and other colleagues on the CHC in the loop and seek your support in helping with that dialogue if we need your forbearance and engagement.
Not a problem, Mark. I'm too happy to help.
So, Jackie, just so you know, I've got a list of Adrian, Francon, Deborah, and Jill wanting to come in. So, Adrian was first, and you've got Francon, Deborah, and Jill.
Right, we'll take them in that order. So, Adrian, if you'd like to come in.
Yeah, thank you, chairs. Just wanted to say, I guess, on Sean's sort of comment on the swallowing assessment. Sean, we'll take that away. I know Gareth is on the call at the moment, so that's handy from a therapies point of view. I'm presuming it was probably therapies and/or radiology that were involved in that. So we'll take that away and come back to you. We have tried to do consultations by phone where possible, so that patients aren't waiting if there is an appropriate way for them to receive some advice. But we can look at that. I mean, Jill has talked about diagnostics and about diagnostic and treatment centres, and just emphasising that we are looking at ways of maximising what we do within diagnostics with the facilities that we have, and also looking at how we bring in additional facilities and resources in to assist with that. I'll leave it there. Thank you very much.
Francom, do you want to come in?
Yeah, I'm just waiting for the nod. Thanks, Jackie. Obviously, it's a very difficult position we find ourselves in, but I was interested in whether we now know where we sit in comparison with other health boards in terms of, the worsening picture. And if it was worse than it was pre-COVID, whether there's any tactics that we can play, if that's the appropriate wording, in the discussions with Welsh Government to accelerate some of the investments on things like the diagnostic centre and so on and so forth that you mentioned.
Thank you, Francon.
In terms of our numbers, obviously our numbers are bigger because we're a bigger health board, but certainly the number I've seen, every health board has a significant backlog of patients to be seen. In turn, I don't know if Jill wants to come in terms of the second part of your question. Can I just repeat the second part, please?
It was the
tactics.
Yeah, and also just on the point I accept, we're a bigger health board and all the rest of it, but whether we can analyse, if that's the appropriate word, and see whether the positioning is worsening or accelerating greater than other health boards, and whether we can then, and this is the second part of the question, whether we can deploy some tactics, if that's the appropriate word, then to change that worsening position into an advantage in discussions with Welsh Government regarding potential funding.
Shall I make a comment on tactics, Jackie? Because it's political more than anything. So I'm confident that the engagement that's taking place with Welsh Government, either via Jill and the Chief Executive's Office of Welsh Government, or via myself and the Minister's Office, is as clear as it could be. The key point, I think, is Finance and Performance Committee on the 29th, when, as I say, the delivery unit for Welsh Government will be present. But to follow up on that, Francon and colleagues, a meeting's gone in the diary between Jill, her counterpart in NHS Wales, myself and the Minister, to discuss the outcome of Finance Performance Committee and our proposals around diagnostic and treatment centres in that regard, so that we're keeping the dialogue going at ministerial level too, Francon, around how we move forward and the wish to move forward quickly. There is a separate conversation, as you know, around trying to leverage some support from Welsh Government more broadly to support service transformation and improvement. And that dialogue is continuing in the background too. So I would hope that we will get the support we need in some way, shape or form, and that we'll know that fairly soon into November.
Thank you, Mark.
Deborah, do you want to come in?
What Adrian has said, so just in terms of the approach around a telephone call.
We seem to have lost Deborah. Jill, do you want to come in?
If I may, Chair, it was just to pick up on some of the points that were made around the Diagnostic Treatment Centre. I would reflect that the option we put in is for two of those, so that we are serving North Wales as equitably as we can. And just to add to Mark's point about the conversations that are taking place, there are also conversations taking place between Welsh Government and certainly I was involved, and the Royal College of Surgeons, in terms of how we can get that work up and running for the sake of patients, but also to ensure that our clinicians are maintaining their competence moving forward. The other point I would make is that clearly, and we're training, it's more training than the consultants that we've got in place currently, but it's making sure that we can train the new ones. Sure, Arpan, you can come in on that if necessary. The second point I would say, and we're very, very conscious that we have that border with England, and that is something that we've discussed with the Welsh Government in terms of our reliance historically on some of a lot of our patients going into England for care, and clearly we're seeing that has reduced quite significantly. So we've got a double impact here, that the Diagnostic Treatment Centre and the Elective Care Centre, as we're beginning to call it, would give us sustainability moving forward. Clearly none of these are quick fixes, but we'd really, really appreciate you working with us, both with our population, but also to help us progress this as quickly as we can.
Thank you, Jill. Deborah, are you back? No? Gavin, this is one of the diagnostic issues that I've got, and it's a form of diagnostics which is around screening. At the start of the pandemic, screening services were pulled back. These have now restarted, but with a reduced capacity. This, I think, is due to the strict C19 regulations, such as cleaning, etc., etc. But patients are being called for screening in a prioritised manner, such as the high-risk patients are coming in first. The diabetic eye screening, I believe, is one of the last screening services to be restarted and is going to be the most challenging one to recover. My question is twofold. Have the Health Board taken into account how this delay in screening is going to impact on them, with patients presenting further along in their condition due to the delay? And secondly, this reduced service will cause delays in additional diagnosis for some time to come in all screening areas. And have Public Health Wales any plans to deal with this? Thank you. Gavin, you're muted.
Can you hear me?
Yes, I can hear you now.
So it's a real concern for the health.
You're muted again.
Can I try and come in and answer for Gavin, because I think he's struggling a little bit with muting. Can you hear me, Jackie?
Yes, that's fine, Chris.
Right. I mean, you make an absolutely valid point. And the diabetic screening, I'll use that, which is the point that you put forward. I'll use to sort of illustrate an answer. We know in terms of the cohort of patients that have had their diabetic eye monitoring postponed, which of those on that list are the ones who were previously developing any warning signs. We know which have for a long period of time had absolutely positive results when they've been really good eye screening, and whose control in their diabetes, for example, has been really good previously. And pulling all of that information together, starting to stratify how we pick up returning that screening, so that we are absolutely screening first those who are at the highest risk of having had any intervening deteriorations to pick up. Alongside that, and the reason for doing that is so that firstly we're seeing everybody in the right order, but also so that we can start to see those individuals who haven't been screened because they weren't even part of the screening service before all of this has started. I mean, you'll understand it's a huge logistical piece of work, and there's diabetes there as one example. But we are doing all of that in partnership with colleagues in public health, with colleagues running national screening programs. For example, the eye screening program is a national program. Absolutely, with the point that you make in mind, which is that we absolutely have to see the people with the greatest risk first as we work through this backlog. So there are plans covering a multitude of chronic disease and screening monitoring, not just diabetic eyes.
Thank you, Chris. Gavin, thank you very much for your presentation. It was appreciated. And
thank you very much.
Thank you. Chris? We're going back now to agenda item 5.1. which is your agenda item, which is the COVID-19 update.
Okay, thank you, Chair. I will just share the presentation now. If somebody could just give me a quick shout out to say that they can see it.
Yeah, it's fine.
Great. Okay. Yes, I was asked to provide you with an update from coronavirus, and I'm going to cover this broadly, and I'll obviously pick up any questions afterwards. As we are all very acutely aware, the levels of infections for coronavirus within our communities has been increasing for a number of weeks now. That's absolutely in keeping with other areas of the UK, and just as other areas of the UK have experienced, we are also experiencing increases in hospital admissions, and are expecting those increases to continue in the coming weeks. I'll come on to some of the numbers towards the end. I think there are some myths that we do need to just dispel. And I think the first one of those is in terms of who in the community are currently experiencing coronavirus infections. It is not a problem that is limited to young people, or those people that we might loosely refer to as engaging in socially active experiences, such as going to the pub or having all-night parties, all the sorts of things that we would like to suggest students do, for example. If you look at the chart here, you'll see that the distribution across our age ranges is pretty broad. The grey covers those people under the age of 30. The yellow and the red covers those individuals over the age of 30. And you'll see it is absolutely spread across those age ranges, and not just limited to young people. And we need to be really clear about that, because what that also means is that we would expect to see an increase in hospitalisation as this continues, because it is those older age groups who, generally speaking, are most likely to be affected more seriously. It's also right and proper to reflect upon some of the differences now compared to the first time through coronavirus wave. Treatments have undoubtedly improved. I've put dexamethasone there as but one example. We are using those treatments in North Wales to good effect, but it still does not take away the fact that coronavirus is a serious illness for many. I'd like to make a loud and proud call out for our research teams in the Health Board. We've got a really active research profile when it comes to coronavirus here in North Wales, and the teams are contributing to international learning in a fairly big way. We're heavily involved in a number of research studies, and are throwing a lot of effort into this at a time when our clinicians and the support staff in our research teams are already under a lot of pressure. So we really are valuing our contribution. Theresa may well have picked this up earlier, but it is important nonetheless to repeat. We're doing a lot of work at the moment in terms of understanding how we will roll out coronavirus vaccination once it becomes available. This is a massive logistical challenge for lots of different reasons. I won't go into all of the details here, but trying to deliver such a big vaccination profile whilst socially distancing, whilst not being absolutely clear when those vaccinations will become available, is pretty challenging. I'm going to call out the research team again, because we're involved in some of the research that is currently going on in phase 3 studies for coronavirus vaccination. And I am going to remind everybody that we're not all about coronavirus. We do also need to remember that the flu season is upon us. flu vaccination is available. Again, the flu vaccination this year is an unprecedented challenge, both in terms of the number of people presenting for vaccination, but also in terms of how we vaccinate in a socially distanced fashion. It's really important to get your flu vaccination as soon as possible, not least because we know there will be a time delay between which you can have the flu vaccine and then a subsequent coronavirus vaccine. So we don't want lots of people waiting to later points in the flu season to have their vaccination, because that will then have a knock-on effect upon the coronavirus vaccination if a vaccine becomes available within those timescales. In terms of our action planning, moving into this second wave of activity, we work very much in a partnership fashion, and we've got a very formalised and effective partnership approach between agencies. That's us, that's the local authorities, police, fire, ambulance service, Welsh Government, military, lots of other contributors besides, working to mutually support each other and make sure that we make the best in terms of our planning, so that we're ready for any eventuality. And we are planning against multiple theoretical scenarios, and it wouldn't be right to share some of those plans in detail, because there are so many of them covering different aspects of what might happen if numbers increase in a particular area, or how we have to move things around to accommodate them. But suffice to say today, that planning is very much underway and progressing very well under the complex situation. In terms of primary and community services, we have a once for Wales approach when it comes to primary and community services, where we have an agreed triage of activities that can be undertaken at different points in time. Primary care is not closed. It never has been closed. In fact, primary care colleagues are providing more consultations now than previously. But as Sian has referred to earlier, and others, some of those consultations are in a very different format to historically. When I refer to primary and community services, I'm talking about dental, optometry, pharmacy, as well as general practice. And I'm talking about all of our wellbeing services, because we are absolutely working in partnership when it comes to how we plan to deliver community nursing and how social care interacts with community medical care. In terms of secondary care services, we've been revising our pathways, the pathways that we created for the first wave, to reflect both our learning but also the learning of other health organisations, to ensure that they remain the best possible pathways for our current knowledge. Members will probably be aware that we are now testing all of our inpatients at the point of admission, and that is something that has been made possible by the increased availability of testing as we've moved through the pandemic, and is an important part of our plan going into second wave. Very early on in the first phase, we started testing care home patients before discharge, and we've maintained that all the way through and will continue to do so. And Gavin has touched slightly upon surge planning and some of the activity that is underway in terms of how we make best use of the resource that we have, reflecting the levels of activity at any point in time, while still remaining safe and socially distanced. At that point, it's probably worth just touching very briefly upon our MVIS hospitals, because that surge and escalation planning includes how we use our MVIS hospitals, and there's a really difficult balance in terms of how we do this. I think we would all say that we would love to have access to the additional space that the Envis hospitals would provide us right here, right now. The flip side of that, of course, is that having more patients spread in more different hospital or environments makes it much more difficult to coordinate their care, make sure that their care is as effective as possible, that social care colleagues can keep a track of those individuals that they need to be assessing, who are now spread over increased numbers of sites. It also, of course, creates very significant challenges in terms of how we staff those spaces and ensure that individuals are kept safe across. So it is a balancing act, and we're being very careful now in making sure that we have escalation plans that mean we use that space as soon as we need it, as soon as that tipping point occurs, but that we don't use additional space where actually the balance isn't there and we will be causing more difficulties than fixing. Finally, I did say that I would touch upon the numbers. On the top left there, you'll see a chart which is coming from general practice. General practice is where almost all NHS consultations occur, and it's a useful opportunity then to monitor the presentations that they're seeing. And we have seen over the course of the last 6 weeks or so a consistent increase in coronavirus type presentations occurring in general practice. That creates very significant difficulties for them in terms of how they're able to safely deliver those consultations. But it is important to pick up on the fact that that is being felt within the community, and it is an important part of our early warning system. The map on the right shows our local authorities in terms of the heat of current community activity, and this is Public Health Wales data. The chart in blue shows the difference in the last 2 weeks, where our incidence for every 100,000 residents has changed from 39 up to 124. That's a significant increase. The number of positive results there, you'll see it has increased in a number of hundreds, whilst doing a similar amount of tests. So we can't explain this by just the fact that testing has increased. There is clearly increased activity in North Wales for us. We are seeing our inpatient activity starting to increase. The numbers here are the most recent confirmed numbers when I prepared the slide set from the 13th, which show 46 inpatients and 4 requiring ventilatory or critical care. We will see those numbers increase over the coming weeks for the reasons that I've told you. I'll stop there and happy to pick up any questions.
Thank you, Chris. Much appreciated. Mark, I'm going to have to go to you to tell me who's got their hand up.
No one at the moment, Jackie.
So no questions for Chris on this presentation? Fine, well, thank you for that, Chris, and we'll go on to your next one, if we may, which is the outbreak management.
That's been covered, Jackie.
I thought you covered it, but as it's an agenda item, I was just making sure. So is Arpangu with us?
I'm here.
You're there. Lovely. I believe you're going to speak now on vascular services.
Thank you, Chair. Thanks, John, for the slides. So just to introduce myself very briefly, so I've recently taken over as acting Executive Medical Director for the Health Board. But I think many of you met me when I was also presenting at the last meeting, which seems a long time ago. a long time ago. So I just thought that it would be an opportunity really to talk about vascular services in the context of the progress of the task and finish group that all of you are aware was set up in May this year. And it was to be chaired by the Executive Medical Director to oversee how we implemented the vascular services review and recommendations. So what follows is an account of what we have managed to achieve. And I think it would be absolutely the right thing to say that the work of the task and finish group has really been enriched by the presence of Adrian Drapey and Richard Bladen from the CHC, and their inputs have really sort of worked immensely well within the deliberations as a mark of collaboration. So one of the key things that we were very keen to make sure that we provided within the task and finish group's work was an external and professional and an unbiased review of the vascular service. So it's really good to let all of you know that very recently, as of last week, we have received confirmation from the Royal College of Surgeons that in combination with the Vascular Society, they will agree, they have agreed to undertake an invited review. We have confirmed the terms and conditions of that review, and we are just beginning to go through the paperwork. And the areas that are to be reviewed are obviously of extreme importance in terms of how we can use the information that will be gathered during this exercise to improve the condition of the service. And just to sort of flag up also that whilst we wait for the external review to commence, we have also started some internal work. So for instance, on the slide, you'll see the second bullet point, which is about behaviors and team working. And we are going to undertake, and the plan is now concluded, to undertake a baseline safety culture survey within the team. Some of you may be aware that this is an internationally validated method by which we can actually ascertain the behavioral elements of a particular clinical team and how that impacts onto the outcomes for patients, particularly in terms of quality and safety. So just to say that we are not just relying on external review, but we are actually commence some work in terms of strengthening the service further. Can I have the next slide? Thank you. So in August, a joint CHC and exec team visit took place to Glencoed Hospital, and the visiting team members, and I'm sure many of you were part of that team, were involved in the care and management of vascular patients and met with team members. The feedback from that meeting has really been very good and has further enabled the service to understand not only some of their successes, but also highlighted the challenges that are facing the service and how we can work together to make things even better. One of the things that we've been very aware of is how we reconcile in the vascular action plan, the vascular bed base, and aligned to that is really firming up our pathways of care. Now, previously in her conversation and discussion, Teresa and others have mentioned the clinical advisory group, which is a multidisciplinary clinical group which we set up during our COVID response, and that group has been very involved now with vascular services as well. And what that group does in a multidisciplinary, unbiased way is check and challenge our pathways of care and make sure that they are the best that we can provide to our patients. So the pathways of care are being checked through and examined through the CAG, or the clinical advisory group, and we now have a set of dates when these pathways are going through. And I do believe that that particular process was also improve the communication within the organization and the engagement process between the various sites that are delivering the service, and will further increase the quality and safety of the service as well. Next slide, please, John. So as I said, the alignment of the vascular beds forms part of the development of the clinical pathways. And this work is ongoing. So for instance, I can report that last week there was a successful meeting in YG in the West on how we firm up and confirm the arrangements in terms of patients who require vascular inputs and have groin abscesses, and how we can care for them the best possible way. I've mentioned already the work of the clinical advisory group and how that's actually now integrated into the work of the vascular task and finish group. And for instance, as we move along the slides, you find that the recovery plan for vascular, i.e. how vascular services will continue to function within the constraints of COVID-19 are also being facilitated by discussions through the clinical advisory group. One of the key aspects that the task and finish group was looking into was development of a non-arterial diabetic foot pathway. And we were very, very clear that what we wanted to deliver for the patients of North Wales was something that was of the latest evidence-based standards and adherent to recognized pathways such as the NICE guidance. So it's pleasing to report that, that quite a lot of progress has been made along that. So we have managed to secure recently program management support, and we've also been very fortunate to identify one of our colleagues in Betsi, who's a clinician who's very involved with the national pathway in Wales, and Gareth Lloyd Hughes is going to work with the pathway and clinical colleagues, i.e. medical colleagues, and others to make sure that this particular pathway, which is a truly multidisciplinary pathway and not strictly vascular in nature, progresses further. Next slide, please, John. Thank you. So in terms of communication and engagement, this is a particular piece of work also being monitored through the task and finish group. And there is much collaborative work which is going on with CHC colleagues, with patients and carer representatives, and significant work is being undertaken by the Corporate Patient Safety and Experience Department as well. We've had a joint review of patient information very recently on the 9th, and we are working towards how we can look at online resources once this work is further completed. One of the key features of this piece of work was to examine vascular patient-reported experience measures and patient-reported outcome measures. In terms of the PROMS work, we have been liaising with nationally in Wales and beyond. One of the issues that we have now realized is there is actually a lack of validated PROMS measures, patient-reported outcome measures in vascular surgery. So one of the pieces of work we're actually trying to develop is whether we can develop a vascular PROMS from North Wales. So there is some innovative work we are looking at in terms of how we can actually inform the quality of our work here, not just in North Wales, but if we can bring this about, it will inform vascular surgery across the UK. And there has been validation of the PREMS questionnaire as well recently. One of the really exciting developments, I think, is the quality and safety dashboard, and I've got a screenshot coming up very soon. This is a really welcome development, and to be honest, this is something that we could probably try and replicate for many of our other services. And when you see the screenshot of that, you'll see that in a very dynamic fashion, it allows us to monitor the quality and the effectiveness of the service. And there are a number of parameters that we can constantly look at, compare, and this will allow us to get some early warnings if there are problems, but also pick up some of the good stuff that's happening by looking at trends on a dynamic basis. And this is very much aligned to corporate dashboard as well. And in terms of our patient safety aspects, obviously we have further confirmed that clinical effectiveness and safety measures will go through the normal corporate quality governance channel, then we reported. Next slide, please, John. So this is just a screenshot. I expect you can't really see many of the details, but this is a digital platform, and as data is put in, you can actually see all of these parameters dynamically changing, and it gives us lots of very good data. Once again, apologize, it doesn't project very well. But if you look at some of the tabs, for instance, on the right-hand side of your screen, we are actually able to drill down to individual surgeons' performances, which is really, really good in terms of being able to monitor the quality and the effectiveness of the service that we are providing on a constant and consistent basis. Next slide, please, John. So one of the other things that that Gavin particularly mentioned, that even in challenging times, we have managed to provide the emergency vascular services, and they have continued throughout the pandemic, although acknowledged freely because of the situation, the capacity has been reduced in outpatients and daycare theatres. Next slide, please, John. And these are just some of numbers in terms of April to end of August 2020, of the kind of procedures that we have still managed to keep going and fed the data back into our processes. Next slide, please, John. One of the things that is ongoing and recently been confirmed is the North Wales Vascular Surgery COVID-19 Recovery Plan. As I said, this was presented, challenged, and has now been endorsed by the Clinical Advisory Group and has been further approved as being the operating model by Gavin McDonald and the slide. So that's a kind of a rapid overview of where we are in terms of making progress in the task and finish group. I'm happy to take any further questions. Thank you.
Jeff and Jill have got their hands up, Jackie, but I'm not sure whether that was from the last item.
Jeff, do you want to come in?
Yes. Adrian and Richard have been closely involved in the task and finish group. Richard has recently been in hospital and will be reporting in detail on his experiences. The CHC will be repeating its public engagement on vascular services, and we will be doing that at the point when the directorate is able to say to us, this is how this service is now ready. We've achieved everything we wanted to achieve, and at that point we will be going out again and seeking patient experience, and that might be more difficult than it was before the pandemic, but we will be doing it. Thank you. I don't know if it's Richard's hand up.
No, it's not.
No. We will. Richard's. I'd say he is preparing his a report on his experiences actually using the service in recent weeks, and we will share that with you. We'll continue to report to all those who attended the Safe Space events about the progress. Very pleased to see that there is the independent invited review. I don't know if we yet have a date for that though, or a likely date.
We are working through that, Jeff, in terms of the target dates and the paperwork. There is a fair amount of paperwork we need to complete ourselves, and as I said, we only recently received all the documents from the Royal College of Surgeons. So we'll be working through that, and the intention is So this week we have a meeting of the Task and Finish group coming up very soon. We have a further report going to the quality and safety part of the organisations through QSC reporting as well. So as we update it, we'll obviously upload the organisation as well as our partners through the processes.
Yeah, and I think it's important that when we've had that, we're able to think about it, to report it to the people who use the services. I'm not sure whether you're aware, but there is in South Wales, they're going through a similar process of reorganising vascular services into a hub and spoke model. I think they start from a different point than us, but we've supplied them with our various reports so that they can learn from them. I think
that, Jeff, that would be very helpful. We have been in contact with South Wales recently, particularly because we wanted to touch base with them to see if they had done any work with the prompt. But they had the same response as we have managed to figure out through our research, is that there is an international lack of prompts in vascular surgeries.
The lead surgeon is a guy called Kevin Conway over in Cwm Taff, or what used to be Cwm Taff. And I've given contact details to people through here. I think the directorate manager is Victoria Legree. I can send you those details shortly.
That'll be very helpful. Yeah. Thank you so much.
I believe Richard is available to speak. Richard?
Yes, I am. Yes, Alpan, we've got a meeting this afternoon, and I will give you my thoughts from my stay on Ward 3 and what my thoughts were on the service I received. So I'll give that the verbal one, but I'm presently finishing the report on the matter.
Thank you, Richard. That is going to be really, really helpful. Thank you.
Jackie, can I make a comment, please?
Yes, certainly, Mark.
So I don't know what Jeff and Richard thought, but I thought the visit that we carried out with CHC colleagues to Vascular, it's not the first time I've been to see the YGC Centre, was helpful. And I also found the people we saw, particularly some of the clinical staff, to be frank in terms of some of the things that were working well, but some of the concerns they've got about what needs to improve. And I thought they were pretty open about that with us.
I agree, Mark, and they were extremely enthusiastic as well in their approach. It was encouraging seeing that, and I think all of us went away from that meeting feeling quite enthusiastic.
Yes.
Good, thank you. Thank you.
To be honest, if I may, book chairs, I think the staff themselves were very encouraged by that visit and felt that there was an ability to have that dialogue openly, and I think there is certainly, I can sense that the spirit of sort of using the principles of continuously improving by listening and learning. So we hope to encourage and facilitate that through the organisation.
Thank you. Richard, do you want to add anything else, or can I bring Jill in now?
From my side, I have my thoughts, but I think we have we are working with the Vascular Task and Finish group to try to provide what we had previously, but trying to look at the improvements that are going on in YGC. And there are lots of positives, and we just need to iron out some issues that I found when I was there. But overall, your staff are excellent. I have no issues whatsoever with staff. And I think there is certainly positive, let's say that.
Thank you, Richard. I'll make sure that I pass on the compliments to the team.
Okay.
Thank you.
Thank you, Richard. Jill, do you want to come in?
It was an observation, if I may, Chair. It was just to thank Richard and your colleagues for supporting us in this piece of work, because I think actually the way that we have come together on this plan is an example of how we can work together in the future. And I know that when Jeff and I spoke, we certainly thought it was a model that perhaps we could use within mental health as well. So I just wanted to thank you, Richard, for your contribution and others, because it has been really helpful.
Okay, my real push is to give that the patient should be centric, and that's what we need to work towards.
Thank you, Richard. Thank you, Jill.
Okay.
Have we any further questions for Arpan? No?
Chairman, Chairman.
Yes?
I think this I don't have to tell everybody that this remains an issue that's very much in the public eye and very much a subject of concern. So I think it's important that wherever there is good progress, we're reporting that. As I've mentioned, we are going to all those who attended the events, but it would be useful for us to continue to do that and to work with the health board to report the progress. And then at the appropriate time, when the service is as Arpan and his colleagues would want to see it, at that point we will carry out another engagement. Thank you, Chair.
Thanks, Jeff. So thank you very much for your presentation, and hopefully in the not too distant future you can come back and tell us how successful it is continuing to be.
Thank you
very much.
Thank you.
The next presentation, we're back to Chris Stockport again, and this is around the closure of the Penrose Polish Nursing Home. Chris, over to you.
Thank you, Chair. Okay, so you should now see my slide set. As colleagues are aware, the Polish home Penrose over just outside Pwllheli has for some time been having difficulties. Those difficulties are multifactorial. They have had some difficulties financially, in terms of staffing, and in terms of meeting the standards that are currently expected by the regulators, and have been working through trying to square off how they can best resolve and respond to those. We've been working with them, as have other partners and the regulators, as I referred to, with absolutely a clear common goal of ensuring that those who are resident in the home, that their welfare is of our primary focus and paramount to everything. Unfortunately, the board of the society that runs the home concluded recently that they were unable to continue, and consequently gave notice to ourselves and the local authority to that effect. We've continued then to work in terms of understanding this, and moved from the initial position of helping the board understand how they can deliver ongoing care in the home, to a position of working out what the best solutions are moving forward, having received that final position from the society board. The view that we've held as we've moved forward in that is to recognise that the services moving forward will need to be different from currently, for lots of very legitimate reasons. And also that we need to be absolutely clear that whilst we wish the care to be of the highest possible standard for those individuals within the home, that we ensure that the impact of the society's decision has been minimised as far as possible, and any transition of service is as smooth as it possibly can be. With that in mind, we have secured agreement from Welsh Government in terms of how we can make additional funding available so that the home is able to stay open safely whilst we work through a safe transfer and focus around individual needs. And that funding partly contributes to staffing support, some governance support to maintain the expectations that the regulator has laid down, and also some support in terms of how we're working in partnership with those involved to make sure that the solution works best for everybody to be able to maintain in a sustainable way. I want to be absolutely clear on some points, and the first is that we, as a health board and as a partnership, recognise that there is insufficient care provision in the Clean Peninsula at present to serve the residents of the Clean, or rather to serve the residents of the Clean as we move forwards, and in part that relates to the changing demographics. An example being dementia care, and actually how can we best care for those individuals who have both dementia needs and non-dementia nursing needs, for example, and how is that done in other areas of the UK where such situations have arisen. So this is an opportunity, albeit a very unfortunate situation, but an opportunity to be clear that what we are investing in going forward is a solution that isn't going to bring us back to this point in 12 months, 24 months, 5 years time, but that is a solution that is fit going forwards. We have formed a project group, and that group now has been meeting. And the scope of that group is to be very clear in terms of providing guidelines for what fit for purpose, safe and sustainable services would look like for those individuals that have not just been served by the Polish Home, but are actually more widely in that geographical area. It's not just limited to nursing care beds, but of course has to involve nursing care beds. It's absolutely imperative that it's not the view of the health board, that it's the view of all of those involved, not least those people currently using those facilities and their families. And for that reason, the partnership project group that is now meeting is chaired by the local authority, not chaired by ourselves, and we're absolutely clear that it has to bring in the wide and varied views that will lead us to the best possible solution. With that in mind, now is a good opportunity just to be clear that anybody who wishes to contribute, whether formally on the project group or on some of the subgroups or stakeholder events that will lead us to that appropriate conclusion. Anyone who wishes to contribute is absolutely warmly welcomed and can contact either myself, the local authority, or colleagues in the West who are already on the board. We will then consider those proposals with our partners. That absolutely includes colleagues here today. We have a timescale that is aligned with the local authority requirements and when they need to take this back through their processes. focused upon implementing improved services as quickly as possible, but the right improved services for the reasons that I have already referred to. Thanks, Jack.
Thank you, Chris. I know we'll probably have some comments and questions on this, but
yeah.
A couple of things that spring to mind. I noticed that you've covered quite a few of our concerns, and I go back to the lack of provision to start with on the clean. There isn't adequate provision now, and I believe that it has been mooted that we could perhaps use Brimberrel as one of these answers to this. My understanding and what I've seen of Brimberrel doesn't give me much confidence that it is the right setting, or that we can afford to lose the bed space that we would need in order to put this discipline in it. And I don't think Brimberrel would be a satisfactory solution. The other thing that I'm concerned about, and I know other colleagues are the fact that we need to keep these people within the confines of the communities, and also we need to be able to allow them to use the Welsh language and looking at that sort of thing. Now, I take on board what you said about project boards and how you're looking at this and how the Welsh Government have found some money to keep it open for a while. But there are 15, 18 NHS beds in this facility. We don't want to lose those beds. And I would hope that whatever decisions you come to around this could constitute major service change, in which we would be very, very keen on seeing at the earliest opportunity, because these are beds that we can't afford to lose in this area. That's what I've got, but I know we've probably got questions of colleagues.
Can I respond to those then first? So from a Brimberrel perspective, I absolutely agree with you. There is no appropriate use of Brimberrel in the longer term for individuals currently in a Polish home. I think where this has gained some momentum has been that has formed part of our emergency plan should, in the early phases of this, the society find themselves in a position where they had to almost shut up overnight. And it was right and proper that we had a plan for that. That no longer is a significant risk to us. And the use of Brimberrel for that purpose, for any purpose in the longer term, isn't something that we're considering. However, Brimberrel isn't just about the community beds. It's also about the teams that work out of those beds and the outreach that those teams can be doing to help support this cohort. So we do need to be clear, we're not talking about moving individuals into those beds longer term. We're talking about the teams supporting those beds, also supporting individuals out in the community, which is good practice. And as I say, the plan was really, should we find ourselves in a very precipitous situation, which I'm very pleased to say we're not in, albeit that this is a serious situation that we wish to move through. Absolutely acknowledge that individuals need to be within their local communities or the communities that they choose, and that language and social interaction within those communities absolutely a part of well-being. We are committed to that. We are committed to it being the right provision rather than the provision that fails to meet what is considered to be best regulatory standard. In terms of the major service change, absolutely, I wouldn't expect you to be involved in this at the earliest point. If we believe this to be major service change, I would expect us to be including you all the way through this as we get to that point, and very, very warmly welcome anybody that wishes to be part of that.
Thank you, Chris. I think what does, a little thing that does concern me is, and I nothing to substantiate this, but I do believe that some patients are being transferred and some staff are leaving already. I will take on board your invitation to go look at this process from the beginning, and I'll take that up with Carol and Jeff at the office, and I'm sure we can put something in place. Jeff, do you want to come in?
Yeah, I think this is very good news, particularly that the solution is moving forward rapidly. I think that's really important. I think we could come out of this with something that's actually better than what we've got now. Involving all those community staff in this, I think, is absolutely essential, right? So I'm very pleased to hear the positive comments at this meeting.
Thanks, Jeff.
Thank you.
Jackie, can I make a comment, please?
Certainly, Mark.
So I think some of the coverage and some of the some comments from some political stakeholders have suggested that the ball is firmly in our court and we're the ones who are holding anything up. I would just want to express support for what Chris has said. Yeah, this is the solution will have to be a partnership one. It doesn't lie solely with the health board. So ensuring that the work of the task and finish group involving our partners moves forward, and it moves forward together, is really important to arriving at the right solution. You know, we want to do all that we can, but we can't do it all ourselves.
I appreciate that, Mark, and I appreciate that there is a definite need in this instance, because they're not all national health beds, and the local authorities do need to take some ownership of this. But we do need to be there at the beginning to ensure that the rights and the... Thank you.
I agree with that, Jackie.
Thanks, Chris. Are there any more questions for Chris on this issue? No, there doesn't appear to be, Chris. So thank you very, very much for your presentation on that. And I believe it's over to you, Mark.
So, Chris, we're moving on to the dentistry update. So another presentation from your good self.
Okay, thank you very much. So I'll take this in the same way as previously and just run through the presentation initially. I was asked to comment upon the fact that access to dentistry during the pandemic has been, in the words of the question, a fraction of that prior to the pandemic, and what are our plans? So when we all talk about the pandemic, then we all think about hospitals. Sometimes we think about general practice. Sometimes we think about other aspects of the NHS, but we don't always think about the impact that it has upon some professions like the dental services. But as you would imagine, I suppose, it has had a very significant impact upon those services too, for very good safety reasons. And as a consequence to that, we have followed a plan in the Health Board, which is an All Wales plan that we've contributed to, and that is based very much upon how we can stratify our activity so that we're able to deal with those complex procedures that are urgent in a way that ensures everybody remains safe. The problem with dentistry is that many of the procedures that they undertake are what we would call aerosol generating procedures, and aerosol generating procedures are a real issue for us with coronavirus. I mean, lots of things are an issue with coronavirus, but the problem with the aerosols that when a procedure generates aerosols is that they put those other people in the vicinity at a significantly greater risk of exposure to coronavirus. Now, that then means that to deliver care when undertaking these procedures, you need an enhanced form of PPE, and I'll come on to that in a moment. And that reduces but does not eliminate the risk to those staff. And it's probably a fair point now just to remind everybody that certainly in the first wave of coronavirus, something in the order of 1 in 50 deaths in the UK was a frontline health or social care worker who just came to work to do their job. So the risk to staff is really important, but it isn't just the risk to staff, it's the risk to those people that then go into the surgery afterwards, because even with the right PPE in place, even if you take it off properly and put it on properly, all of which is time consuming, the premises have got to be right too, with the appropriate circulation of air. Rooms have to be empty after a procedure and then cleaned down in a very particular way. All of which then is done to reduce the risk to as low a possible levels as we can get them, which is not zero. It means that a dental surgery that might have previously provided 30 procedures is now only able to provide 4 or 5 in the same period of time. So really challenging from a time perspective. The picture here shows a dentist kitted up accordingly. The dentist has got a face mask on, which is called an FFP3 mask. These have to be fitted to the individual and then checked to make sure that they are appropriately fit. They don't fit everybody, and different brands of mask need to be checked separately because not all brands fit in the same way. They then have the full face shield on, a fluid repellent gown, and as I say, enhanced room ventilation. It is incredibly difficult to work for a long period of time in a fluid repellent gown, as I'm sure colleagues will realise. The procedures that generate aerosols in dentistry involve drilling and descaling. So even if you don't then need drilling procedure to be done, it's actually sometimes quite difficult to fully understand what the problem is without undergoing some descaling activity. So lots and lots of presentations into dental services do unfortunately generate AGPs. We have a red, amber, green approach for dentistry, which reflects that all Wales approach. And during April and June, we across Wales were at a red phase for dentistry, and that meant that face-to-face activity was minimised as far as possible. That where these procedures needed to be undertaken, they were undertaken on a reduced number of sites with a reduced number of dental practitioners and associated staff providing that treatment, so that we were able to ensure that their risks were as minimum, had been minimised as far as possible. In July, we made the decision across Wales that we could step dentistry down to amber, which reflected the fact that general numbers within the community of coronavirus had started to decrease. And that brought about a reintroduction of some of these procedures on more sites and a return, albeit not to pre-pandemic levels, but a return of more face-to-face dental appointments. The amber phase had a clear strategy within it, which ensured that those folk that had to have temporary treatments whilst were in the red phase were prioritised, and we weren't in the situation that we referred to earlier with diabetic eye screening of starting to see people outside of order, or that those people continued to be disadvantaged who had required earlier treatment. And what that means, bearing in mind that PPE is still required, what that has meant is that the most routine of treatments, checkups where there aren't any complications, routine scale and polishes, that type of activity, has had to be delayed and will have to be delayed as we catch up that more urgent activity. And dental teams are all now positioned to increase their activity, and that catch-up is proceeding. Of course, we're now heading into a second wave, and only time will tell what level of upsurge we experience. It may potentially be that we end up heading back into a red phase within dentistry, although we haven't made that decision presently, but there is that risk. So we will need to monitor that progress. But broadly speaking, that is the plan, and as soon as possible move from amber back into a green phase. The last comment I would just make is there's been an enormous amount of work here, both amongst private contractors and amongst the Health Board dental team, to try and keep as much activity going as possible, focusing upon the activity that is most urgent. But despite all of the effort that has gone into doing that, the team have also been progressing the work that we've previously spoken here about in terms of the dental training unit that we have planned for North Wales. That's part of bringing in new dentists, and not just dentists, but other professionals who support dentists and who could do more if we were able to provide state-of-the-art training in North Wales that was focused upon that. So those plans have continued. Welsh Government and university colleagues have been supporting us with that, and we will continue those over the coming months to try and bring the dental training unit to fruition as quickly as possible, recognising that the pandemic has to some degree got in the way.
No.
Okay.
Yeah, stand by. Let's just come back in. Oh. Okay, so I'm not showing any hands up. Does anybody want to?
Celia Haywood.
Oh, sorry, I've now got Celia showing. Celia, do you want to pose a question?
Yes, thank you, Chair. I'm delighted to hear that things are moving forward with training for dentistry in North Wales. But could I just ask Dr. Stockport, what is the procedure for emergency? So I can appreciate that checkups and descaling and the routine dentistry we all understand can't carry on. But if somebody ends up in acute pain, which can happen very quickly, what is the process for those people? What do they actually do to get some form of treatment?
Okay, thank you. So all patients who are currently under the care of their own dentist can contact their own dentist, and there are agreed pathways for emergency treatment with individual dentists, which mean that where possible they'll deliver what care they are able to do. If it requires aerosol generating procedure and is considered to still be urgent, but that dentist is unable to deliver that within their premises, then we have arrangements where they can refer to one of our enhanced centres to deliver that. So I'd advise that people contact their own dentist first. Where individuals don't have their own dentist, then our emergency dental service continues exactly as it did do before in being able to deliver all emergency treatments, and our emergency dental services are all equipped to deliver aerosol generating procedures where that's necessary.
Can I just ask on the emergency dental service, how many centres do you have in North Wales that can deliver this treatment?
So we currently run health board centres from our major conurbations, so the big towns, rather than smaller communities where volumes are difficult. But one of the steps that we have taken during the pandemic is to approach some of those high street dentists who are able to provide aerosol generating procedures and offer additional activity to those dentists to provide some additional emergency treatment. If an individual needs to contact the emergency dental service because they don't have their own local dentist to seek advice from, then they can contact the service through NHS Direct. And the service will be able to then discuss with that individual which the nearest or most convenient location is for that individual.
Thanks very much. Thank you.
No, right. Any other questions? I can't see any flag. No. Just one comment from me, Chris, that you're well aware of. So I attended all of the community hospitals, the other week in the West, having been to the centre and east before that. My visits coincided with dentists coming back into community hospitals, and it was good to see they were glad to be back and wanted to be back, and they were offering some ideas about how they could increase the throughput of patients, which I know we've accepted in some respects of the recommendations in the West. So it was just to see them back in the workplace so enthusiastic, I think is important and important to our patients.
Thanks, Mike.
Okay, so final item is special measures. Over to you, Jill.
Thank you, Mark. If I may, I'm just going to take you through some points in this paper because I'm assuming everyone's read it, but also clearly this has moved it on. Part of that journey has been compounded by what has actually taken over a lot of this agenda, which is the impact of COVID-19. But I'd like to identify the areas where we feel that we have made some progress, but also reflect back on some of the areas that we've got some work to do. One of the things I want to put front and centre of this, I think, Adrian, you referred to it, this is about putting the patient front and centre and our public. So we're really, really keen to build on the relationship that we have with yourselves to help with that engagement of what our services need to look like, to inform our clinical strategy. We've done a huge amount of work over the last few months to build on our clinical strategy, driven by COVID, actually, with our clinicians coming together to look at services and look at them on a pan-North Wales basis to see how we can best keep people safe from harm and prioritise the treatments that we need to give. And we've alluded to some of that today. We know that we've got challenges in mental health, but we have strengthened the leadership in that area. I'm not going to go back through Theresa's presentation, which she gave most eloquently earlier on, which I think outlined where we believe we've got those challenges in mental health and how we intend to take those forward. And that is very much a partnership agenda, and we welcome the conversations, Jeff, that we had with yourself and Carol and the wider teams as to how we can progress that and how you can support us with the engagement. I'd also like to advise you that we have recently brought in someone called Simon Evans to support us on our governance journey. We've made a lot of changes with the board governance and the organisational governance, including our risk, how we manage risk. And Simon is sitting alongside us now to help us progress those at some pace. Clearly, one of the other challenges has been the stable leadership. So we're looking forward to welcoming Joe in January, and we're already out to recruit against key posts, including the medical director, executive medical director. In terms of performance, that's been a really difficult one because clearly now we are measuring harm rather than measuring times waiting. And we are working closely with Welsh Government alongside the rest of Welsh health providers of how we can be transparent on how we are managing that moving forward. And clearly, I think Mark, you alluded to it earlier. We are working with Welsh Government to see what support packages can be put in place so that we can think more strategically, particularly around some of our mental health services, but also how we deliver planned care and unplanned care more strategically moving forward, rather than trying to do that on an ad hoc basis. So there's a lot going on here. I'm happy to take questions. It is a bit of a crossroads right now in terms of moving out of some of those more difficult ways of working around RTT or time waiting for treatment to, as I say, that harm-based, which I think is the right way forward, patient-focused approach. But what we are really, really conscious of is the clinical strategy and the conversation we've had on the diagnostic treatment centres, for example, to be able to drive us forward on that on a long-term basis rather than a short-term basis. I'm more than happy to take any questions. I'm sure other members of the executive team will be.
Okay, I've got no hands showing. Does anybody want to come in and pose any questions? Stella, I think you want to come in.
Chair, I just wondered how you're measuring these harm-based, because, things can be very subjective to the individual person. So I just wondered how you're doing that.
How we're doing that is we're doing that clinically, Stella. So we're working with very closely with our clinicians who are prioritising that very much on an individual basis. I'd also say it's difficult. I'm not going to lie, it's difficult because people who are at risk of harm or are not at risk of harm today may be tomorrow. So this is absolutely a fluid conversation. So you don't fit in one category and stay there. This is meaning that we're having to manage these thousands of patients dynamically, and that's not just for operations. It's obviously for diagnostics and other outpatient visits, etc. We're also conscious that some people, and I think it was alluded to earlier, there is digital poverty out there. Not everyone can undertake a virtual appointment. So again, we're trying to prioritise those that most need. That might be hands-on, but it also may mean that we acknowledge that a video consultation is not the right thing for that individual. So we are working really hard and very dynamically to get this right, and we're very much working with our clinicians and working on college guidance. Arpan, I don't know whether you want to add to that, but it is very dynamic and ongoing.
Yeah, I'm absolutely just going to support what Jill has said. We do have as Jill has said, it's not perfect science, of course, and we have to balance individual risks and go through the entire process of what we know as clinicians, as well as match that up with what the current situation is. We are helped a little bit in all of that objectivity by a risk matrix that has been forthcoming from many of the colleges and many of the specialist societies as well. So that does provide the clinician with the additional support of making sure that we get it as right as we can for the patient.
Oh, thank you very much. I think the risk matrix answered the question a bit more, than what.
Yeah, so each of, you're welcome. Each of the colleges have a risk matrix. So depending on which specialty it is, they'll apply their own risk. So it's not. The other thing I would say is that our GPs, primary care, with the Consultant Connect principle that we've put in place, if they feel a patient is deteriorating and they need additional support, we have made it easier for our GPs to access that specialist support. And I think, Chris, that is going down very well with our GP colleagues.
Thank you very much.
Indeed it is, yeah.
Okay, thank you.
Thanks, Stella. So I think, as Jill has alluded to, the next few months are key in terms of how we move forward as an organisation, and particularly in a special measures context. So the first thing is that we'll be looking to ensure that we have a substantive executive team, and we are out to market, for example, in terms of the medical director. That will be important now that we've got a new chief executive coming in. Second thing is, in that regard, we'll want to ensure that the direction for the organisation, the priorities certainly for the next few months, are clear. And that's why the plan this afternoon is really important. And I personally think the plan that we're seeing this afternoon is in a better place than previous plans. Then there is the ongoing dialogue with Welsh Government about what we are in special measures for, and how we compare with others in that respect, or those respects, because in some areas that we are being listed for special measures, we are better performing than other health boards, and therefore we need to bring that framework into a position slightly different, at least, to what it is now, while still focusing on the areas that need to be focused upon, like mental health. And then alongside that is the work that's already been done to offer a coherent approach, in particular to plan care, that Welsh Government feel is founded on a detailed analysis of our demand and capacity, which they then can feel they can support as a platform for moving forward. And as I say, those conversations are taking place at the moment, and I would expect that we'll be in a clearer position with Welsh Government on all those fronts before we get to Christmas. That's certainly the aim. So the next few weeks and a few months are really key to moving the conversation forward, and that's what we're determined to do. I don't have any other hands showing, so if colleagues are happy, we'll move on to the last item, which is the date of the, which is May, which as ever seems a long way off. Jackie and Jeff, we are, that relies on your discretion to a degree. So, if something arises or you want us to reconvene, either in a smaller group or as board to board, then please feel free to tell us, because that's just that's a marker in the sand. I'm more than happy to respond to your needs and concerns where we need to.
Thank you very much, Mark. We will take your kind offer up should the need arise. Thank you.
Okay, and it's been a pleasure to chair this meeting with you, Jackie. I think we've done okay between us. We seem to stay on track.
Well, we finished on time.
We did, yeah. Okay, so thank you. Thanks, Jackie. So, Jock and everybody, may you have a good day and a good weekend, and so on and so forth, and see you soon. Thanks very much.
Thank you, Mark.